We are so fortunate today to have Dr. Eveline Staub and Professor Martin Kluckow join us today, join me and Chris. Dr. Eveline Staub is a specialist in general paediatrics, neonatology and paediatric intensive care. She's currently a neonatologist at Royal North Shore Hospital, focusing on clinical work with patients and families, researching the development of blood vessels and kidneys after preterm birth and the long-term consequences of being born prematurely. Professor Martin Kluckow is a senior staff specialist in neonatology at Royal North Shore Hospital and is also a professor in neonatology at the University of Sydney. Martin and his team develop and conduct new clinical studies in their quest to understand the problems with heart function in premature and sick infants receiving intensive care at Royal North Shore Hospital and in several collaborating hospitals around Australia. Anyone who's come along to one of our previous webinars will know our wonderful ambassador, Chris Russell, who facilitates these webinars for us. Chris donates so much of his time to work with us and to share the work that our researchers are doing with all of our supporters in such a simple and easy to understand way. And we are just beyond grateful for everything that Chris does for us. So thank you so much. I don't want to take up any more of your time. I'll hand you over now to Chris and Eveline and Martin.
Yeah, hi Jenny, and happy Christmas to everyone. In fact, I was just thinking this morning, how appropriate is it to be talking about birth and start of life issues at Christmas, you know, which celebrates the start of life of Jesus himself. So extraordinary coincidence, really. And we spent so much time in these webinars talking about my end of life. It's nice to actually be talking about things that involve the starting of life and how effective that can be, looking at that in terms of our future health and later on, and things that I had no idea about. Martin, you've been part of this sort of area of research for a long time. What's the state of the nation in terms of your understanding of the links between issues at the beginning of life and issues that we might face later on in our lives?
Thanks very much, Chris, and thanks for the introduction, Jenny, and happy Christmas to all of you who've joined us, and thanks so much for coming along to listen to what we're doing and what we're hoping to do in the future. Chris has already mentioned that Eveline and I are both neonatologists, and so that is newborn babies, and particularly premature babies and sick babies, and we've had a long-term interest in research in preterm babies into their cardiovascular heart function. And the Heart Research Australia has been a wonderful supporter of ours now for almost 25 years. We've had that collaboration, and in that time we've developed many new interesting areas which have had impacts both nationally and internationally. But to your question, Chris, I think one of the more exciting things that's been happening in the last few years is that in many areas of newborn medicine, we've been starting to realise that what happens when those young lives and premature lives are in our hands, when we're actually looking after them in an intensive care unit setting, many of the things we're doing in those first few days and weeks of life, we're now discovering can impact further on down the line when we get older, into adolescence, young adults, and we're starting now to look at older adults as well who've been through the process of being born prematurely. Because in the past we weren't able to look after very premature babies, so we didn't have many of them coming up into adulthood. So some exciting work is now happening from the point of view of heart function and kidney function, and Dr. Staub is leading that in our unit. But I think the key message here, Chris, is that in a number of areas, what we've discovered is what we do in the preterm baby in their care can impact their health later on, and Eveline will expand on that in the area that she's researching in a little bit later in the discussion, I'm sure. But it's an exciting thing because it's something that we potentially can do something about early on in the nursery, or even if it's just a matter of screening to see if there's problems like high blood pressure or problems with blood vessels into the future. Where now our eyes are being open to this through the research that's being done within the neonatal intensive care unit. And it's now becoming an issue for adult cardiologists because there's many ex-preterm babies who are now moving into adulthood. And so it's a learning curve for the adult cardiologists as well as for ourselves at the pointy end looking after the babies.
So are we talking about screening, or are we talking about preemptively stopping things happening later on?
Well, I suppose always it'd be nice to stop, to cure, to stop, to avoid things happening, but that's not always easy, and they're quite complex things we're talking about. So the other option is to at least be aware of these issues, the longer term issues, and to screen for them, so that if we do find, for example, a young child has developed high blood pressure, and that's a possibility from a preterm baby's point of view, then we can then actually take some steps to monitor and possibly manage that problem. Otherwise, in the past, it may have been a hidden risk factor for our babies.
So, Eveline, you know, you're moving into this area, you've been in it for a while, you've got a lot of experience and a lot of ideas on this. What are you specifically focusing on? There seems to be a lot of potential things you could focus on, but what's your main focus?
Yeah, that's correct, Chris. Thank you. My main focus is the notion that being born early does something to the growth of your small and large blood vessels. And I'm focusing on the tiny little blood vessels, those vessels that distribute the blood through every organ. And we think that being born early means that less of those very small blood vessels grow. And those who do grow, are smaller. Now that seems to be, you know, a bit of a hidden issue. And we've not really been able to demonstrate very well that this is happening. And what I'm working on is essentially a world first, a way of visualizing, of looking at the growth of those very small blood vessels in real time. So while the babies are in our NICU, we're doing those very specialized ultrasounds that we can look at the very tiny blood vessels in the kidneys, because that's a very accessible organ to do that. But essentially, you could probably do it in many other organs as well.
And when you say very small blood vessels, are these blood vessels that if you were studying anatomy at uni, you wouldn't learn about because they don't normally exist, or so are they new ones, or are they actually supposed to be there, they're just small?
Yeah, so they're what we call capillaries. So the tiniest blood vessels at the end of our blood vessel tree. You know, you've got the heart that feeds blood into the largest blood vessels, the aorta and such, and then it distributes into the organs, and within the organs it branches, and then it goes into the tiniest blood vessels, which are the capillaries. And I often compare it to, you know, the big highway, the M1 that comes down into Sydney, and then when it comes into the city, it goes into bigger sort of, you know, streets, and then at the end it goes into the tiny streets in the neighborhoods, and that's the capillaries. And you can also then, like, you know, compare what's happening in, say, one of those, if those small streets get clogged up, or there are less of those, it clogs up right into the big arteries or the big highways that feed the city, and then that causes problems. So if you want to distribute the same amount of traffic into lesser small streets, you're going to have a problem.
I hear you, but when a baby's born, you know, the development of those, how is that going to increase blood pressure when the baby grows up, and obviously all its vessels and everything grow as well? Where's the link there?
Yeah, so the link, a very good question, Chris. So the link, we think, is the organs need blood flow, right? They need oxygen, and that's fed through blood going into the organs. And the purpose of the capillaries, of the tiniest blood vessels, is to distribute that blood with the oxygen into every corner of every organ. And then with preterm babies, where we think there are less of those tiny capillaries, of those tiny blood vessels, the same amount of blood with that oxygen needs to go through less of small blood vessels. So that is a lot more work for the heart to pump it into lesser blood vessels. That's essentially what we think is happening on that front. On top of that, just to add on to that, it's not just the small blood vessels. We know that even the big blood vessels, or the aorta, for example, is stiffer in babies that were born early and then grow into adults. So that's another extra factor. You know, we all know well in adults and older people, when the walls of the blood vessels get stiff, that's not very good for your heart either. So it's all these sort of extra little add-ons that at the end of the day then will cause a higher risk of high blood pressure and heart disease.
So am I being too simplistic if I say that your heart is kind of working hard, so it's getting fitter, which means it's stronger, which means it's pumping harder, and that's actually a bad thing?
Yeah, absolutely. You're very correct.
So
yeah.
like a muscle-bound athlete.
Yeah. Absolutely.
Okay. And how does this affect your kidneys?
Well, the interplay between kidney and heart is very intimate. Unfortunately, often it sort of is looked at two separate systems, but really they're very, very intimately connected. Particularly because the kidneys are the most important organs to regulate blood pressure. They tell the body how much blood pressure should be generated. And imagine if these tiny blood vessels are less well developed in the kidneys, as probably everywhere in the body. The kidney kind of think, oh, I'm not getting enough blood. Please put up that blood pressure so I'm getting more blood. So that's this sort of then vicious circle that's going to happen.
Okay, so is the answer you take all these little blood vessels out when the premature baby's born so that it doesn't push the blood through them or block them off, or, what do you do?
I think the answer lies in growing them better, to make sure this process of not developing as well, that we can counteract that and make sure this problem of not having enough of those small blood vessels doesn't occur.
So why do they grow better when they're inside mum's tum than they do when they're born?
Very good question. So living inside mom's tummy means that you're living in an environment of not so much oxygen. We often say the oxygen content inside mommy's tummy is like being on Mount Everest. So it's not very much oxygen around. And that's okay, because that's how nature has set this up very cleverly. And not having a lot of oxygen around is a very good incentive for blood vessels to grow, because I think, oh, we need to distribute our blood, our oxygen better, let's grow. And then when the babies are born early, all of a sudden, just even in room air, there's a lot more oxygen around. And then the blood vessels think, if you want to do this anthropomorphic thing, they think, oh, we don't need to grow anymore. There's so much oxygen around. Let's just stop growing for a bit. And that's what happens. We know that very well, for example, because we can watch this process in the back of the eye, on the retina, the blood vessels. But then as the baby continues to grow outside of mother's womb, the oxygen demand grows again. So blood vessels realize, okay, we need to grow again. So they will, but probably not in a normal fashion compared to what would happen if the baby had stayed inside.
All right. Well, I mean, Martin, can I come to you and talk? You guys love Latin stuff. I saw this initial PDA and I thought it probably stood for something like probable duct, artificialness or something, but it doesn't. It's got some great long Latin name. But what is a PDA in a baby, and what effect does that have in all this process?
Thanks, Chris. And it's pretty easy. PDA, patent ductus arteriosus. That's not.
Oh, simple. Yeah, sure.
Simple. So for those of you who've followed our work that's been supported by Heart Research Australia for so long, we've had an interest in a number of areas along the way, all of them in either premature or sick babies. And it's ranged from interest in blood pressure and maintaining the blood pressure in the first few hours of life, through to the timing of the umbilical cord clamping, and when the right time is to do that, and how that affects the heart and the function of the heart. And also this interesting little blood vessel called the PDA, patent ductus arteriosus. So patent means open. Ductus arteriosus means it's a connection between two parts of two of the big blood vessels that come out of the heart, the one that goes to the body, the one that goes to the lung. And there's actually a communication between those two. And
they shouldn't be there, or it is?
Well, it's there when the baby is a fetus, when the baby's inside. And in fact, it's very important when the baby's inside, because there is no air in the lungs. And so the heart doesn't need to waste energy pumping blood through the lungs because there is no air. The oxygen and the nutrients are being gained from the placenta. So this ductus arteriosus is actually there to divert blood from the blood vessel that goes to the lungs through to the body blood vessels. And so we don't waste time pumping blood through the lungs, which are empty of air. And that's its role. What should happen when the baby gets born at term is that very quickly that duct does close down, and yes, it disappears, and it shouldn't be there in a baby. It should only be there in a fetus. when we look after these tiny little babies, and we can look after babies as early as 16, 17 weeks before their due date, so 22 or 23 weeks of pregnancy, the muscle in that PDA or ductus arteriosus is not strong enough in those small babies to close the duct off in that first few days. So it stays open. So that's what the patent means. It stays open. And as a result of that, can start to cause troubles. And those troubles, ironically, relate to stealing blood away from the body and causing low blood pressure and low blood flow to essential organs, and pushing excess blood into the lungs, which are now full of air. But in fact, that duct should be closed and not bypassing, or in the case of preterm babies, pushing extra blood through the lungs, which then causes a series of complications. So that it's a very pesky little blood vessel, which we spent a lot of time trying to work out how to treat, how to manage. Some of the treatments we've got to have a series of nasty side effects. So we're always balancing up, should we treat or should we not treat the PDA?
Can you just sew it up, or what do you do?
No, we've got some medications which cause it to constrict. And some of them are like simple medications like ibuprofen, you might have heard of, or Brufen. Paracetamol, they're drugs that we actually can use to close the duct, because those drugs have specific actions on the muscle in the wall of the ductus.
And you mentioned before about the importance of deciding when you're going to clamp off the umbilical cord. You know, where's that come into it? Because I see, you know, I mean, what's the current school of thought about that?
Well, that's been a fascinating journey, because if you think about it, the clamping of the umbilical cord early is probably one of the most it is the most performed medical procedure in the world. So in natural settings of animals giving birth, or in more lower countries where there's not Western medicine, nobody clamps the umbilical cord at 1 minute of age, or 10 seconds of age, or 20 seconds of age. That's something that we do in developed countries, because we feel that it reduces, or we felt that it reduced other complications. But as it turns out, and actually it's probably not a good thing to clamp the umbilical cord, particularly before the baby's had a breath and started breathing. And often in the setting of, in our setting, looking after very sick babies, often at birth, they're not immediately taking their first breath, and we really have to help them with that. And to help them, we clamp the umbilical cord first. And the body of work that I've been involved in has said that's actually not the right thing to do. And it's actually better to leave the umbilical cord to contract down by itself gradually. And in that time, a little bit of blood will transfer from the placenta to the baby. And it will also help the heart. So the heart doesn't get put under as much stress as it might otherwise have got put under if we clamp the cord suddenly within the first 10, 20 seconds. So the recommendation now is to wait at least a minute, 60 seconds. It doesn't seem like long, wait a minute, but it's potentially going to make a big difference to the outcome of babies, not just in westernized countries, but in developing countries. And we've just actually published the last paper in the series of papers that we've published looking at early versus later clamping of the cord. And it shows amazingly a reduction in about 30% reduction in mortality in premature infants if we just simply wait till 60 seconds rather than do it at 10 seconds, which is an amazing outcome for a procedure which is so easy to do in any setting, just waiting 60 seconds.
That is amazing. So if you've got all this knowledge now, I'm assuming this is all recorded now with premature babies. So if you're then starting to grow up and all this is known about what happened when you were born, when they clamped it, what small blood vessels they've got, etc., what do you then tell that person to do when they're older, because you know all these things, that they've got all these small blood vessels and everything? What's the recommended advice then?
I think Eveline will take that. So.
Yes, yeah, Chris. You know, funny that you asked, because there at the moment, and particularly also in Australia, there is no official recommendation how to follow up adults or adolescents that were born preterm. So that's definitely something we are intending to work on. And as we increase our knowledge, how exactly this all happens, like the knowledge is there that adolescents and young adults who were born early have a higher risk of high blood pressure, have a higher risk of heart disease, have a higher, even die, unfortunately, more often from cardiovascular disease and lung disease. but there is no official recommendations on how to follow them up at that stage. So it's very much something we're working on while we're still gathering knowledge and trying to figure out, can we actually prevent this from happening? I think one of the massive steps is going to be to tell GPs, to tell their families, hey, you're essentially a preterm baby for life. As much as those families would like to forget that, you know, all those weeks and months that they spent in the nursery where they had so much, you know, heartache and worries over their little children, they want to just go and leave this behind. And unfortunately, we need to start formulating the message. Yes, you know, we're pretty sure you're going to live a good life. You're going to live a happy life. Most of them have a life free of disability. So even the tiniest babies now grow up, you know, with a relatively normal development. They go to school, they, you know, you've probably seen our Christmas campaign of this amazing young lady, Paris, who was so tiny and used to sat her HSC and has done really, really beautifully. But we need to tell them, if you need to be careful, need to be live a healthy life, because we know that you have a slightly higher risk of have high blood pressure and heart disease. So first step, for example, would be that we start recording at what gestational age, at what week of pregnancies children are born. And up until quite recently, that wasn't the case in New South Wales. So, you know, GPs don't know that their patients were born early if they haven't followed them from the get-go. So that's one piece of work that we need to work on. And then we need to educate our families, go home, be happy with your children, they've done beautifully, but please, when they grow up, please bring them to your GP at least once a year for a blood pressure checkup, for a heart health check, for a kidney health check. We know very well how early screening and then intervention can prevent major complications from those problems. So what we know, you know, in a slightly older population, 30, 40, 50 years, when you start doing those yearly checkups with GPs, we know that they work equally well when you start them early. So that's one big aspect, I think, of my work, is to get the knowledge out, get the awareness out, and on a government level, for example, to really have the information for GPs, a flag that goes up and say, hey, this patient of yours actually was born 3 months early and she was only a kilogram. Please make sure the kidneys and the heart health and the blood pressure are okay.
So, Eveline, are the issues, are they arithmetically or are they geometrically a lot bigger the earlier the baby? In other words, the difference between being a week early and 13 weeks, is that an arithmetic progression, or is that does that go up by the square of the problem?
Not by the square, but like sort of proportionally. So the younger the baby was born, the more likely the problems are going to be. We thought for a long time, we thought it only affects the really extremely preterm babies, so those born less than 3 months early. And it's true that those actually have double the risk of having high blood pressure when they grow up. But we're acknowledging more and more that even born sort of slightly preterm. So preterm babies mean they're born less than 3 weeks before their due date, so 37 weeks. So even, you know, those late preterm, so close to 37 weeks, say 34, 35 weeks, even those have a slightly higher risk. So the education needs to go for everyone, but it's particularly important for our smallest.
So what's the earliest, survivable preterm baby now? With current technology.
It's a moving feast, Chris. So and Martin will also will have many more stories of that. But I started my training roughly sort of 18 years ago, where looking after baby born at 24 weeks was the absolute exception, and we would still scratch our head whether we should or should not do that. And these days, 24 weeks, so 16 weeks before due date, it's often not even a discussion anymore. We routinely look after babies born at 23 weeks, so 17 weeks early. And there are several places around the world who much more routinely look now after babies born at 22 weeks. I mean, we're pushing the agenda. It's difficult to start with, but the more we try, the better we get at it, and the better the outcomes are going to be.
So my wonderful daughter was born 6 weeks early. I remember when she was born, I could actually, her head sat in my fingers and her feet came down to about my wrist. And I remember looking at her and thinking, what a miracle. But yeah. I really should be saying to her, you need to keep an eye on blood pressure and all those things at about 6 weeks early.
That would be lovely. Yes, absolutely. Yes.
And this is probably a stupid question to either of you, but if the baby stays in the womb longer, if it's late being delivered, does that mean their blood vessels have grown even more and even better? Or is there a kind of point of where there's an optimum point you don't need to have any more blood vessels?
There's a reason why pregnancy is to last 40 weeks. We rarely push more than a week past that. Obviously, a lot of that is decision and managed by obstetricians. But the placenta, this beautiful organ that looks after the baby in utero inside the womb, is not meant to look after the baby for much longer than 40 weeks. And what I can't specifically answer the question about blood vessels because we have actually not looked at this in the setting of being post-dates, but more than a week longer is probably not much point because the placenta is not meant to look after the baby, and then it will suffer all sorts of other problems if you don't get them out at that stage.
So, Martin, could I ask you, you've been doing this for a long time with Heart Research Australia. What have Heart Research Australia been funding, and what's been that collaboration between your work and the donors and people who have put their money into Heart Research Australia?
Thanks, Chris. And I mean, I'd like to thank everybody online who's been involved in our research, and particularly the people with Heart Research Australia who have kept up a continuous bond with us over, as I say, almost 25 years. And that's really unusual in research, to have long-term funding in that way. And that really allows you to plan ahead, to be able to know that you could take on new studies and new work, and that there's going to be the ability to have the staff and the equipment and the medications, etc., that are required to run those sort of clinical studies. So we're very grateful to that consistent support that's been given by Heart Research Australia. So what does that achieve? Well, within 25 years, we've had over 70 articles published in the area of heart function and what happens during the heart in this transition from the fetus to the newborn. All of those things I mentioned earlier about the patent ductus arteriosus, cord clamping, blood pressure. It starts with just measuring the normal values and understanding normal, because often we don't have that, and Eveline's just at the starting point of recording the normals in yet a new area. And then it's identifying the abnormal and working out treatments and ways to bring abnormal back to normal. So it's pretty simple. And so we've had a series of studies early on that did that. And then once we see that we can bring normal to abnormal, then doing something like we would call randomizing, so putting babies in one group or another to receive treatment to bring back to normal or not receive treatment, and then see what the outcomes are just in the short term, and eventually in some of our studies right into the long term, into babies who are 2 years out of the nursery setting. What effect does what we did in that first few days and weeks of life have out to 2 years? And you've heard from Eveline that will now go out to even further. So it's enabled us, the continuity of funding has enabled us to continue to have a continuous set of research running to do this, measuring normal, finding about abnormal, treating abnormal, working out the effect that has, and then repeating that again with each new area that we've achieved in. And we've mentioned the patent ductus arteriosus. We also had blood pressure and blood flow. We've had the cord clamping studies. And currently we're looking at the interrelationship between lung treatments and how that affects the heart, because one of the other big areas we look after is the lungs in preterm babies. What's the impact of some of the things we do in the lung on the cardiovascular system and the heart? So that's the sort of the newer area that we're moving into. The other, so part of it's support for medications, staff time, particularly research time. The other side of it has been providing equipment, and to do a lot of our studies to understand the heart, just like in adults, we need an ultrasound machine to look at the heart and the heart function. And we've been very lucky to have particularly the Heart Research Australia and in coordination with Millhouse Foundation have really been a continual supporter of our heart ultrasound machine and enabled and facilitated the research that we've done. A lot of the information is collected non-invasively by using an ultrasound machine to measure the cardiac function, the blood flow, the blood pressure, what happens after the cord's being clamped. We're constantly there with an ultrasound, which we can bring to the bedside. We don't have to actually move babies outside of the intensive care unit to get that data. And they tolerate an ultrasound much better than, for example, what you might do in an adult, a cardiac catheter or some more invasive way of measuring things. And so part of what we've done
I was just going to say, all this work is is sort of looking forward work. One of my frustrations as an agricultural researcher has been how short-term government funding groups think. If you're going to come up with something within a couple of years, before the next election preferably, then you've got a good chance of getting the money. But is that the same with the National Health and Medical Research Council? Are they tend to be short-term, or do you get good support from them as well as from Heart Research Australia?
I'll answer briefly, and then Eveline can talk to this because she's right at the pointy end of getting funding for her studies right at the moment. So I'll speak in the past. I've had a number of NH and MRC funded grants and been involved in them. And what's great is that if an association such as Heart Research is able to provide funding for the initial seeding research, and then what the NH and MRC, the National Health and Medical Research Council, really likes is evidence that a project is likely to be successful, and to be able to provide early data and show that it's feasible is really important. And that's worked really well for me and my groups that I work with. And so I've been either a lead or a co-lead on about 8 NH and MRC trials, and half of those have been seeded by the Heart Research Australia to begin with, and then we've been able to parlay that up into a full grant, which has been great. Eveline, what's your experience with the grant system? Because it's difficult when you're starting out and you don't necessarily.
Yes, absolutely. One of the problems with particularly big grants like NHMRC and Medical Foundation is that they want to see a track record. So starting out, it's really hard to prove, I can do this. This is a worthwhile project. It's a feasible project. And as Martin mentioned, coming into a unit where research is already a culture, it's well accepted, it is seen part of our everyday clinical care even, and then coming into this climate and being able to draw from resources that are there. For example, our research nurse, who's been funded by Heart Research Australia for many, many years, is just absolutely invaluable because it forms a background to exactly show in pilot studies, yes, we can do this, it is feasible, it is not harmful for the children. Please, can we have this big pot of money to eventually, reach big, because that's what we need. We need to reach big. We need to think forward, not just a couple of years, but probably 10, 20 years to really demonstrate that we can have effect on the life of these children.
Yeah, I must say, I've said this to the group before, that I get very frustrated with the amount of time that you guys who are so clever at all this have to waste filling out forms and trying to get money. I mean, that's really, the rest of us should be doing that for you so you can get on with your work and contributing. So maybe I might finish this off by asking both of you, what would your dream of where we might be sitting in 10 years' time in terms of what we'll know and be able to offer babies that are born prematurely to stop them having these problems in the future? Eveline, could I start with you, with where you're going? If you could dream, where would you be dreaming that you'd like to be in 10 years?
A big dream would be that we're at a point with kidney research, particularly where we are with the lungs at the moment. So 20 years ago, we would ventilate small babies and hammer those lungs pretty hard until we realized it's probably not a very good thing to do, that we should be much more gentle. We should pull back much more. We're doing much more what we call non-invasive support for the lungs. And we have realized that this is much better for the lungs, not just in the short, but also in the long term. And I hope my research will help do a very similar things for the kidneys, because eventually if we find a kidney gentle way of treating children, the tiny babies, in the long run, that will help blood pressure issues, that will help heart disease when they grow up to adolescents and young adults and old adults. So this sort of quote or mantra of Heart Research Australia, keeping families together for longer, exactly applies to this as well. After all the heartache they go through when they're in a NICU, to then have a way of treating them that we are gentle on all organs, and particularly the kidneys. That is such a black box still in preterm babies, and it is so important when they grow up. And again, it's the heart and kidney are so intimately related. If we can do something on that front, and together with Martin's research, supporting the heart optimally after birth, that would make for healthy and long living form of
So
pregnancy.
is this, yes, I was going to ask you that, is this more about longevity or is this about quality of life?
Both, because you and I know, and everyone who's listening knows what a big killer heart disease is. So absolutely both.
And Martin, what's your dream of where this might be and what we might be talking about?
Thanks, Chris. So where we're heading and where our research group is heading is a little bit of an extension of what I was just talking about. Is what we've realised is that babies can present with a particular clinical picture. Maybe it's low oxygen, maybe it's low blood pressure, and there's not a single underlying what we call physiology or state which determines that. There's 5 or 6 different ways that a baby could have low blood pressure or low oxygen levels. And in a clinical setting, we often have to guess or try a series of different medications to see if we can work out which is the right treatment for our baby. The advantage of having the skills of being able to measure with ultrasound the underlying what we call physiological state or the way that things are working in this particular infant enables us then to tailor or plan medication that's right for that baby. Now, in the adult world and in our world as well, that's called precision medicine. So that's the new way of thinking. So instead of using a single treatment algorithm to treat babies who've got a particular clinical problem, what we're learning to do is to look behind that problem and measure and understand which category this baby fits into. And then we're going to target our treatment directly to that particular category. And hopefully the baby will then get better more quickly and won't be exposed to unnecessary treatments. So it's really an extension of this understanding normal, understanding abnormal, what brings babies back to normal again, and getting to that point more quickly by gathering information up front about the way we should manage it, rather than just doing a trial and error. Oh, we'll try this medicine because sometimes it works in this setting. And so my dream would then be able to have a comprehensive set of guidelines and all of collecting the data as well. That's the other part of it, which we're getting better at, is getting real-time data so we can actually understand how babies respond. Different babies respond to different treatments and medications. So the tailoring medicine or precision medicine in the area of heart and cardiovascular in the preterm baby is where I'd like to go. And it's we're a long way down the track there, and it's been helped immensely by Heart Research Australia funding our ultrasound machines along the way, and also funding our research nurse who's responsible for collecting really high quality data about the way babies respond to different treatments and approaches that we have in the nursery. So precision medicine for the premature baby, Chris, is where I'm going.
Yes, well, look, prevention is always better than cure, and that sounds like what you're doing here. It's allowing us to know what we're up for, preparing people for taking care of themselves. It's so important. And I guess we say this every time I interview people in this webinar. You can only sit back and say, thank God for Martin and Eveline and the work they're doing. We can only wish you more strength. We hope that our funds that we put into Heart Research Australia just help you get there quicker. And I guess personally, can I thank you for all the work you're doing for us all. And as a heart patient, I've had 17 years of life that I wasn't going to have. I've seen my grandchildren. I've done so many things in that last 17 years, and that's only possible because of the work that you guys are doing, and we're obviously getting earlier and earlier. So thank you so much for talking to me today. And Jenny, can I hand back to you?
Yeah, sure. I completely agree. Thank you so much, guys. The work you do is truly amazing, and we love chatting with you and hearing all the updates as well. I just have I've got some questions which if you don't mind me going through. The first one we've got is, someone wants to know what the annual heart and kidney health check should involve. So if someone's going to their GP, what should they be making sure that their GP does?
At the very least, it should involve a measurement of blood pressure. And if it's found to be borderline or too high, obviously go down that track and make sure you rule out any other issues that could affect that and treat if you need to. In terms of kidney health, that often involves just a urine sample where you look for potential, the kidneys are quite good at compensating, but if they start to lose little amounts of protein in the urine, that's often an indication that something's not quite right. And if there is concerns over, say, fitness to get all those appropriate tests for heart health, that eventually will end up with a specialist consultation with the cardiologist. But at the very least, with the GP, it should be a blood pressure and it should be a urine sample at, once a year.
And if you have a baby who was born prematurely, at what age should you be starting to ask these questions when you go for your doctor's appointments?
One of the issues is that very many GPs cannot measure blood pressures in small toddlers. Firstly, toddlers are not meant to sit still for 30 seconds that it takes to measure blood pressure, so they will often struggle and often will not have the equipment. And again, we don't have firm recommendations in the United States. What they've come up with is at the very least an assessment when they start school, so around 5 to 6 years of age. And then when puberty starts. So that's the sort of absolute minimum. Ideally, you would start with yearly assessments earlier, but it's hard, again, as I said, particularly as GPs who are not often equipped to do that. So start of school, start of puberty, and yearly from then onwards.
Yeah. And have you found with the work that you've been doing, Eveline, any difference between boys and girls in terms of blood pressure development or? Yes,
we have. So the one study that I was involved in back in Switzerland of a cohort of adolescents, so young, almost teenagers that were born early, comparing them to a same-sized group of term-born adolescents, we found that the boys tended to have higher blood pressures. Having said that, that's not uniform around the world. Others have found girls, so we're still figuring the sex difference out.
Yeah. All right, thank you so much to Chris and Eveline and Martin for coming along and joining us today. And thank you to all of the people watching. We are so grateful to you all coming along and sharing your time with us. And I also want to take the time to thank everyone for their amazing support this year. Each and every donation, no matter how small or large that's been donated to us, it truly means the world to us. Everyone's support has been just incredible, and we've just been able to let some of our researchers know that they've had some successful grants that have come through, and we've approved their research funding, and we are so incredibly excited to share that with all of you. We're still finalising some of the details, but I wanted you guys to be the first to know that we do have some new research grants that have been approved, and we will be sharing that with you. So stay tuned to your email, so we'll share that as soon as we can. And thank you so much, everyone. We hope you all have a very Merry Christmas and stay safe and healthy, and we look forward to seeing you all again next year. Thanks so much. Bye.
Thank you very much. Merry Christmas.
Merry Christmas. Thank you all.